Hey, I want to first welcome everybody to Grand Rounds, and I hope you're all doing well. I know the last week we had some challenges with the weather and really created quite a mess throughout the East Coast and beyond, and I hope everybody's staying warm and doing well, and we're just so happy to have you. This is our first of our Grand Rounds this year, and I think this is going to be exciting. I kind of think, to be honest with you, all of us have been involved in Grand Rounds or in lectures and discussions recently about new drugs, and there's been a lot of talk about new drugs, new regimens. You know, the Gates Foundation is trying to come up with a new regimen using totally new drugs, so that maybe once for all we could get a regimen that's more effective, you know, less toxic, be quicker to use, easier to take, less side effects. Boy, doesn't that sound good, right? But the bottom line comes down to is that right now, you know, despite some new drugs, you know, we really still don't have the promises yet that have been fulfilled for a regimen that's more effective or better proven or has better, better efficacy. And we're really at this point kind of still where we were before. But, you know, we really maybe should appreciate a little better what we have. As you know, we've had a very, very effective regimen for the last 50 or 60 years that has really proven itself as a major tool and weapon, you know, in the fight against tuberculosis, with potentially 80 to 90% efficacy and, you know, somewhat tolerable side effects, though any side effects not always tolerable. But the bottom line is that, you know, the Rifamycins really, really were a game changer. They were developed 60 years ago, came on the market, and took a disease that was once the most deadly, you know, and a disease without any kind of effective treatment, and really gave us tools and drugs that gave us a shot at cure. And as you guys know, for the last 60 years, we've had a very good regimen, but it has its problems. And obviously, the big issue is, you know, we may be losing it due to drug resistance, but luckily for the vast majority of patients, the Rifamycins work. You know, the question comes down to, are we really using the Rifamycins as effective as we can? And as you know, there's been some new research that really suggests that maybe we should be using these Rifamycins in a different way, maximizing them. You know, if you look at the physician's desk reference manual and you open it up, what you'll see is that, you know, there's all these warnings about using more than 600 milligrams of Rifampin, that the skies will open, the clouds will turn dark, and, you know, all horrible things will happen. But interestingly enough, we've been using the same dose for people for the last 60 years. But new research is now suggesting that maybe we could be using a higher dose. Maybe with that higher dose, we may get more effective, you know, use of the drug, and most excitingly, even potentially, it may be able to shorten our regimens. And that's why we're lucky today. We're lucky to have Chuck, and I like to call him Chuck, and I know you've heard me introduce Chuck before, but to me, we've been very lucky in the TB field. You know, recently there's been some research that says, you know, if your name is Mary or John, you're more likely to be a genius, you know. But in the TB field, we've been very blessed with Chucks. You know, but to me, in my heart, there's only one Chuck, the Chuck, and that's Chuck Peloquin. And you guys know Chuck. I mean, Chuck's the professor and director of the infectious disease with the College of Pharmacy and Emerging Pathogens with the University of Florida. You know, we've all, probably everybody on this call has had the opportunity to work with Chuck or been interacting with Chuck. And as you know, when it comes to pharmacokinetic issues or pharmacological issues, Chuck is who we turn to. And what we're really lucky to have is Chuck Peloquin is going to today talk about maximizing Rifamycins and some of the issues and some of the potential limitations. And you know that when Chuck is about to speak, it's going to be entertaining and it's definitely going to be memorable. So with that, Chuck, you kill me to say these nice things about you, but sometimes I have to. So Chuck, how are you doing? What's going on?
Well, thank you, David, for that elaborate introduction. I was going to go by Sting, but that name was already taken, so I'm just going to go by Chuck. And today we are, as mentioned, going to be talking about the Rifamycins and what we already know about them and what we can go and use them going forward. So without further ado, according to the WHO, TB is now #1. We're the single most lethal infection on the planet, and that still includes the fact that if you're HIV co-infected and you die, that counts as an HIV death and not as a tuberculosis death. So as you know, roughly 9 million people had active TB last year, and roughly 1.5 million people died from that. So that comes out to one roughly every 20 seconds or 3 per minute. So if I were to talk for about an hour, and I'll go a little bit past that, roughly 180 people will have died by the end of this presentation, and maybe you knew somebody. And this certainly seems to qualify as a serious problem from my standpoint, and I think you would agree with that. And so we have to look for better solutions beyond what we're already doing to try to bring these numbers down more quickly. So what are we looking for? We're looking for highly effective regimens that are shorter than 6 months. And most people accept the fact that the regimen is 6 months, and I'll show some data that in many cases it goes past 6 months. But if we accept for the moment that it's a 6-month regimen, what people are trying to find through experimentation are regimens that are shorter than that. Have we found it? Well, not yet. And as you know, there have been 3 quinolone-based trials that failed to provide sufficient efficacy to replace the current 6-month regimen. That's not to say they didn't work. They just didn't work better, and they didn't work at a rate that would allow those regimens to be only 6 months long. So this is a very nice paper by Drs. Lanois, Chason, and Nuremberger at Johns Hopkins University. I encourage you to check this out in Clinical Infectious Diseases. And they go through these 3 trials, the South Indian trial published in PLOS 1 in 2013, and then the 2 papers in the New England Journal, the REMOC study and the UlfaTub study. So there were some encouraging signs in those papers, but it didn't qualify as a game-changing 4-month regimen. So why not? And the authors go into this in some detail, and again, I encourage you to read their paper. Despite the inconsistent and altogether modest benefits of the fluoroquinolones in phase 2 trials, large phase 3 trials were organized and launched even before all the phase 2 results were available. So there was a little bit of haste involved, and there may have been reasons for that, but nevertheless, it turns out that they might have been a little bit too hasty. And they also go on to say that future phase 2 trials really should enrich for the patients who have the worst form of the disease, the cavitary form of the disease. So if you're trying to come up with a one-size-fits-all regimen, you really need to test it in the worst-case scenarios, the ones with the worst cavitation, such that you can prove across a broad array, including the worst patients, that such a regimen would be effective. The non-cavitary or minimal disease patients still have to be treated, but if the regimen is effective for the worst cases, it should be better for the less severe cases. So this begs the question, should there be a one-size-fits-all regimen? And the answer for me is no. Now, it would be really convenient, and people like convenient. You know, I like toast in the morning, and the fact that the bread is already sliced for me is really convenient. Okay, so that's a situation where convenience is great. But maybe in the treatment of diseases, we can't oversimplify it and have one thing be the right thing for every single patient who comes into the clinic. TB, as you know, is a spectrum of clinical conditions ranging from the mild to the very severe, where you already have destruction of lung tissue. And for most other diseases, whether it's cancer, diabetes, or hypertension, or strokes, we stage those people and we adjust the therapy and the aggressiveness of the therapy based on how we stage those diseases. And we generally don't do that with TB. Now, back to why not. So the quinolones do not appear to have sufficient sterilizing capacity. And as you know, there's sort of 2 flavors of drugs in TB, those that are able to kill the bacilli, but not necessarily all the forms of it that might be in your body. So you can have a drug like isoniazid with great early bactericidal activity, but it may not be a great sterilizing drug. And sterilizing drugs are the most important because those are the drugs that, at the end of the treatment, those are the ones that are going to prevent the post-treatment relapses in the patients. And right now we have 2 drugs that can do that based on the ways that we can measure it. And those would be the pyrazinamide and the class of rifamycins. And the rifamycins include Rifampin, Rifapentine, and Rifabutin. And we'll speak in detail about these 3 drugs. We're not going to speak in detail about pyrazinamide today. So why do we not have a magic 4-month regimen? So Drs. Lenoir, Chason, and Nuremberger go on to speak about this in further detail. And what they say is that there is factors that contribute to the relapse diathesis, and these are multifactorial, and they include higher bacterial burdens in patients with large cavitary lesions, reduced drug penetration to the site of infection, and lack of adequate immune effector function at the cavitary surface. So they also say that low systemic exposures to key sterilizing drugs, the rifamycins and pyrazinamide, due to pharmacokinetic variability among populations, reduces the rate of sputum sterilization. We're going to look at that in animal models, and we're going to look at that in clinical trials. So if we think about these factors, you cannot control higher bacterial burdens. If a patient comes in with a 3-centimeter cavitary lesion, you can't say, well, I'm sorry, this clinic only accepts 1-centimeter cavitary lesions. You can't be treated here. That's not how it works. You get what you get. Whoever comes in the door, however progressed they are, you have to treat them. And there's really not much you can do about the lack of adequate immune effector function at the cavitary surface. I mean, you could feed the patient and give them vitamins. You can give them some amount of bed rest. If they don't have shelter, you can provide that. But you can't really directly stoke the immune function at the cavitary surface. But what can you do? Well, you can address the reduced drug penetration that was discussed by our colleagues from Hopkins. You can control the concentrations, at least in the plasma, and those are the concentrations that drive the amount of drug that enters the cavitary or other lesions where the tuberculosis resides. So why are these soldiers using tracer bullets? For those familiar with the Second World War, you'd recognize these as Sherman tanks. Those are American tanks, and you might have seen the movie Fury, from which this picture is taken. And you can see these flashes coming off the machine guns on these tanks, and those are tracer bullets. And tracer bullets have been used for a long time, and they answer the simple question, am I hitting the target, yes or no? So there's lots of different situations where people use measures to see if they're actually doing what they think they're doing, and you actually can do that in tuberculosis, though you don't use tracer bullets per se. So how do we treat TB currently? The vast majority of TB patients in the United States are treated exclusively with TB drugs. So once you've made the diagnosis and maybe addressed some social issues to the patient, the actual treatment is comprised of typically 4 drugs. So you have to get the drug part right. If you don't get the drug part right, you're really in a world of hurt, because that's 100% of your treatment. Also, the vast majority of TB patients in the U.S. are treated with the same doses of the same drugs, especially isoniazid and rifampin. Now, there are historical reasons why these doses were chosen, but we also have to look back at what those reasons were and see if those reasons still attain today. And certainly in the case of the rifamycins, I would argue, as well as others, that those reasons no longer apply to our current situation. And we'll talk in detail about that. Now, when we use standardized regimen, we are assuming that these doses are the right doses for every situation. In other words, you have the dose for the patient, and every single person who comes in subsequently is the patient, the average patient from the British Medical Research Council trials. And we essentially rule out a priori that the next person coming in might be somewhat different than the person we just saw. Now, if you think about how you manage virtually any other disease, you don't do that. If you're treating hypertension, would you treat every single person with 50 milligrams of atenolol daily? If you had a diabetic patient, would you treat one after the next only with 10 units of regular insulin with each meal? And would you say, I don't care if their glucose is 30 or 300, they're getting 10 units of regular insulin? Or would you treat every stroke patient with 5 milligrams of warfarin once daily? I don't care if they're bleeding out or stroking out, they're getting 5 milligrams. No, that would really be bad practice. And the French term for that is malpraxis. So what do we really do? We treat these patients by monitoring and getting feedback in one form or another to see how we're doing with our treatment. In the case of blood pressure, we have a very convenient measure. We have a blood pressure cuff. We can just put it on the person's arm, we can check the blood pressure, and we can gradually dial up the therapy till we get the blood pressure consistently where we want it. Likewise, we can measure blood glucose multiple times per day to make sure that we're treating the patient appropriately with whatever regimen we select. And likewise, the stroke patients, you would never give everybody the same dose of warfarin. You're going to try to get that Goldilocks, not too high, not too low, just right INR value to make sure that the patient has a high probability of protection for further stroke without a high risk of bleeding diathesis. So virtually every other disease is moving towards personalized or precision medicine. In sharp contrast, TB continues to use standardized regimens that were developed decades ago, and we often don't confirm the adequacy of our doses. So I would say that that does not qualify as precision medicine. It might be convenient medicine, but it's not precise. So in TB treatment, the mantra is that it's 6 months long and it's over 95% effective. And there is some truth to that. If you look at the original British Medical Research Council trials, then you can show that under the per protocol analyses that were done, that is true. So what's a per protocol analysis? Only the patients who actually completed the protocol as designed are included in the data analysis. Now, there's nothing wrong with that, and it's very informative, but you exclude people who are otherwise going to be showing up in your clinic. So if you look at the typical BMRC studies, and there's a lot of them published, and there was a complete review by Fox and Mitchison in 1999 in the so-called Gray Journal, or the International Journal of TB and Lung Disease. So you can pull all of these, and many of them are referenced in the TB guidelines as well. On average, it was about 10% of the patients who were evaluated but not assigned to study, and another 10% approximately dropped out of the study. And each one is a little bit different, but these are typical numbers. So you lose about 20% of the patients who were evaluated that never made it into your data analysis. So if you put them back in the pool, then you're really looking at 75% of the patients who were evaluated in these analyses. So when we talk about this 6-month regimen, well, that was really as applied to 75% of the overall patients. Now, if we look at completion rates in the United States, now we don't track relapse in the United States directly. We have completion rates in the United States. And you could see that at the peak of the rebound or resurgence of TB, only about 64% of the patients were completing therapy. And by 2000, this had really gone up into the low 80s, and it went from maybe 82 to 84 to 85, and now it's around 88, 89% of the patients who complete their therapy in 1 year or less. And the fine print here is a little hard to read, so I will click to the next slide, and now it's not the so fine print, it's the big print. So this is continually updated at the CDC, and this last culling of the data is as of last June, and it includes patients who are alive at diagnosis, were treated with a regimen, and didn't die during therapy. So that seems fair. These are candidates for drug therapy, and they completed the drug therapy. And it excludes patients who had drug resistance or disseminated disease. In other words, these are patients who might otherwise be candidates for a 6-month regimen. Now, if we look at the data where I have more additional data from the CDC, it's the 2010 slide set published in 2013, as you can see here, but the data is up to 2010. But it's really the same data. It looks the same. And when you say completed in 1 year or less, well, it begs the question, how much less? And so I asked the CDC if they could tell me, and they almost instantaneously did. They were very, very helpful, and they provided this table. So if we look at 6 months only, or 6 months or less, only about 1 in 5 patients in the U.S., as of 2010, completed what could be the 6-month regimen in 6 months. And you might argue, well, there's bureaucratic reasons for that. You know, they have to go from perhaps a hospital to the public health service, and you know, there's time for the bureaucracies to talk to one another and transfer patients. Fine. Let's just look at 7 months. Well, that's 45%. It's not 95%. And you would expect that at maximum it could be 88% because that's what the previous slide showed us it was. It was 88% at 1 year. I would encourage the CDC to publish this slide right after the other slide that they always publish in annual slide sets, because this is where we're going to get traction. If we start using alternative methods or different regimens or higher doses, we're going to move these 80 and 90, hopefully, numbers earlier and earlier in treatment. Right? We may not get more than 95% cured, but we can cure them faster. And faster means it's less difficult and less expensive for the TB clinics, and it reduces the time that the patients are exposed to drugs, and it reduces the times that they can have adverse drug reaction. So what? Well, it's supposed to be a 6-month short course regimen, and if it's taking you 12 months or longer, that's not short course anymore. And again, you have to pay for each and every month. There's no BOGOs, buy one, get one free. You can't just say, well, I'm going to pay for the first 6 months and we'll just do the others for free. Well, you have to pay for the drugs and the follow-up and the labs and the DOT for every month that the patient is under your care. So you have an incentive to get it over with. Another thing is that if we look at those original BMRC studies that I was just talking about, we're really not given the same doses anymore. And if we just look at Rifampin, the average weight of those patients who were predominantly male in the Hong Kong and East Africa trials, their weight was only 48 kilograms. So if we take 600 divided by 48, that's 12.5 milligrams per kilogram, which is above the sort of standard 10 milligrams per kilogram that we think about for Rifampin. But if we look at some of the large patients that we have today, then 90 kilograms, while it seems large, is not outrageously large for a U.S. Patient. Then we're only given 6.7 mg per kg, and that's quite a bit different. So it's a really simple concept. If we consider the original study patients to be full of Rifampin, and you could debate that, but if we just consider that the baseline, the gold standard, notice the gold here, if that's the gold standard, then we're really doing something quite different. So if these guys are full, these guys are not full because they're dramatically bigger than the patients who were studied. Another way of looking at it, if you have a little Cooper Mini, you can fill it with 10 gallons of gas. But if you have one of these big Chevy Avalanches, you're not going to fill it with 10 gallons of gas. It may not even be half full, right? So it might be a very manly-looking vehicle with muscular wheel wells and all of this plastic on the back, and what could be better than that? But nevertheless, this manly-looking truck is going to suck a lot of gasoline. And if our big patients are used as an analogy, then you're going to need a lot more drug to fill our big patients. So let's get on to the pharmacokinetics and pharmacodynamics part of the discussion here. And some people are intimidated by these terms, but there's absolutely no reason to be intimidated by these terms, and I'm going to show you lots of pictures of what they mean. Right? So pharmacokinetics is simply what the body does to the drug. The drug goes in, it moves around to different places in the body, and then it goes out. So that's really not that complicated. It's just a long word, but if you like PK, well, then it's suddenly a short word. Right? And in pharmacodynamics, if we're using a drug like an antihypertensive drug, it's what the drug does to the body. In the case of antibiotics, we're going after a parasite of some type inside the body, so we're looking at the ability of a drug to produce an inhibitory or lethal effect against the infecting organism inside of our patient, and hopefully not doing anything else to the patient. Another important concept is the minimal inhibitory concentration, or MIC. And in other disease states, you might see MEC, the minimum effective concentration. But this is really a critical idea. When you get your results back from the laboratory saying it's susceptible or resistant, they might not have done a full MIC testing, but they did sort of the shortcut version, the critical concentration or epidemiological breakpoint concentration. And where did these concentrations come from? Well, it was based on achievable concentrations in humans. Right? So if you go back to the agreements in the 1960s, and all of these are summarized in the book by Leonid Heifetz from the CRC Press that was published in 1991, you can read the long play version of the history of susceptibility testing for TB. But it really comes down to a version of the minimal inhibitory concentration. And if you're below the minimal, you're not inhibiting. It's a real simple concept. You're either over the bar or you're under the bar, or you can actually run into the bar. But you have to take this into account, and it was all tied to achievable human concentrations. So how do these drugs work? A drug is just a chemical. It's just a chemical that we happen to know something about, and it's going to do something desirable in the patient. And in the case of antibiotics, these antibiotics have to find the organism, and it's complete random chance. And then they have to bind to that target inside the organism, and that produces an inhibitory or a lethal effect. So unless the drug is delivered to where the bug is residing, in other words, unless you have adequate PK, nothing happens. You don't get pharmacodynamics or PD. So it either gets there or it doesn't. So here are the pictures that I previously mentioned were coming, and when you look at them, they're really not that hard to understand. So pharmacokinetics is concentrations over time. The drug goes in, it reaches the maximum, and then it is eliminated from the body. So that's pretty straightforward. And then whether we're looking at an in vitro system or an in vivo system or even looking at human data, there's some dose below which nothing happens. And then as the concentrations get higher and higher, something starts to happen, and then you reach concentrations beyond which no more benefit is gained. Right? And then you put those two together and you get effect over time. So these are really not that radically difficult concepts, and there's a lot published about this, so you can read more about it. Specific to antibiotics, we're looking at the area under the curve, or AUC, and this is really what's driving the bus. So here's our MEC or MIC, the minimal inhibitory or minimal effective concentration. And for some drugs, we have the maximally tolerated or minimally toxic concentration, whichever you prefer. And then if you stay below this sort of toxic range and above the minimally effective range, you're in the therapeutic range. And it's not quite so simple, but it's a good illustration of what is going on. Not every TB drug has concentration-related toxicity, so we don't always have to worry about that. Rifampin seems to be largely devoid of that kind of toxicity, whereas ethambutol, yes, if you give enough ethambutol, you can get into problems with ocular toxicity. So we have the peak concentration, or Cmax, and we have this AUC, and those two, relative to the MEC or MIC, is really what we're trying to maximize in order to kill the maximum number of organisms. So the killing of TB by most drugs can be well described by the AUC to MIC, so the area under the curve I just showed you, divided by that MIC or MEC, and more is better, right? So the higher the AUC, the more killing that you get. For drugs that display this kind of activity, and that would include INH, rifampin, PZA, and ethambutol, those are considered concentration-dependent killers. There's another class where having the drug maybe 4 times the MIC for a long time, most of the dosing interval, such as beta-lactams like penicillins and cephalosporins, those are time-dependent drugs. But we're not going to be talking about time-dependent drugs today. Now, all of this has been known for a long, long time. And the earliest studies with the TB drugs basically had this information if they didn't exactly call it by these terms. So again, what we want to do is maximize this AUC relative to the MEC or MIC. And really, this is the whole show right here. And you really need to understand this, and then you're going to keep seeing this slide because it's really the key point about this. The bigger this AUC gets, if this gray area was all the way to the top of the slide, relative to the same MEC, you're going to get more killing, and that's exactly what you want to get. So if you want to read more about it, this is a really nice paper in Nature Medicine last year. Brendan Prideaux, along with Laura Vai, Cliff Berry, and Veronique Dartois, do a really, really nice job discussing the association between sterilizing activity and drug distribution into tuberculosis lesions. So it's not just enough to get it into the plasma. The plasma is delivering it to the lesions themselves. Now, normally we can't measure the lesions in our patients, so we don't have access to that in most clinical circumstances. But in this study, they look at it under experimental circumstances. Also, if you want to read more about optimizing the clinical pharmacology of the tuberculosis medications, my graduate students, now graduated, Eric Egeland and Abdullah Al-Sultan and I wrote this paper also last October. This one is in clinical pharmacology and therapeutics. So this is you. You're so brave you don't even wear a helmet. You got the headphones on. You're barking out orders. Your mouth is open, kind of like Dave Ashkin. And bang, here's another dose being given to your patient. And bang, here's another one. And down here, those are all the doses you've already given, all the shells you've fired. And what's this thingy here? Well, this thingy right here is how you aim, right? Most weapon systems have an aiming device. That's why they have the old saying, ready, aim, fire. And we can actually aim in tuberculosis as we treat patients, and that's something we'll talk about, right? So if you aimed carefully and then bang, you just shot down this airplane and it's not going to blow up your ship, and that's a good thing. But what if you missed? What if you did not aim carefully? Oh, I hate it when that happens. So the old saying, sometimes you get the bear, sometimes the bear gets you. And look at this guy. He's like, oh, shish kebab, right? So he's very unhappy down here. He's got his hands on his head because he knows that his ride home just got blown up. So even though I'm always loath to show target slides in pharmacokinetics because it takes people off the topic I'm trying to get to them, it's easy to explain things using this. So the top left, we have low precision and low accuracy, just all over the place. Here we have high precision. They're all clustered together, but they're not in the middle of the target where we want them. Here we have accuracy if the target is the yellow band out here, but in our case, we want here. We want in the middle. So we have low precision, high accuracy, but not on the target that we're shooting for, and this is what we really want. All of the shots clustered right where we want them. And in this case, it would be all of the drugs being delivered very effectively to the lesions where the TB are and rapidly killing those tuberculosis bacilli. So now on to high doses of rifamycins and rifamycins in general. So here's our friend Rifampin, the best drug ever, and it's one of the primary drugs for TB. It really disrupts the DNA-dependent RNA polymerase, and if you don't have RNA functioning, you're not going to be making any proteins, and things are going to come to a screeching and halt inside of that cell. Rifampin can be given orally or intravenously. The standardized dose is 600 milligrams daily. And I've had a chance to talk with some of the originators of that dose, and Denny Mitchison being one of them. And Denny said, well, you know, Charles, 600 milligrams of rifampin is the minimally effective dose of rifampin. And if you look at the suggested readings for today's presentation, several of those papers discuss that in detail. So I won't belabor the point. There were good historical reasons for picking this dose, but those reasons no longer attain here in 2016. Rifampin is largely cleared by the liver, and it has a low amount of hepatotoxicity. If you give really big doses intermittently, like 1,800 milligrams once a week, then you have, after several months, a probability of flu-like syndrome. But if you give it daily, that doesn't happen. Now, rifapentine is cyclopentyl rifampin. So they took rifampin and they put a lipophilic side chain on it, and that causes rifapentine to stick to plasma proteins, and by doing so, the liver can't get at it and it hangs around longer, so it has a longer half-life. But it's not necessarily the way we would want to get a longer half-life. Everything else is mostly the same as rifampin. It's not available intravenously. Based on the studies which I will present today, we're moving from a 600 milligram, originally twice or once weekly dose, and then 600 daily with study 29, to 1,200 daily with study 29X from the TB Trials Consortium. It's cleared through the liver like rifampin and has similar toxicities to rifampin because it's mostly rifampin. It's cyclopentyl rifampin. And then there's Rifabutin, which is given instead of rifampin for HIV-positive patients or other patients at high risk of drug-drug interactions. So you may remember the old commercials, stuffing instead of potatoes, so here we have Rifabutin instead of rifampin. And it has the same mechanism of action. It's only available orally. The dose varies depending on the other drugs you're giving because there are two-way drug interactions with Rifabutin. It's cleared by the liver, but the toxicities are different than rifampin and rifapentine, and unlike rifampin and rifapentine, the toxicities are concentration dependent. So if we compare these drugs, rifampin used to be the all-star for drug-drug interactions involving cytochrome P453A4, And in the original studies, if you only give Rifapentine twice a week or, for a short period of time, it was a little bit less potent than Rifampin. But if you give it at 1,200 milligrams daily, it's at least as potent an enzyme inducer as Rifampin. So it's not going to help you in those situations where you have a lot of drug-drug interaction potential. Rifapentine is 99% protein bound, and that's not necessarily a good thing. It doesn't have to be a horrible thing, but it's not necessarily a great thing. Rifabutin, a lot less drug-drug interaction potential, but a different set of toxicities. So that's a quick comparison of the three. If we look at their potency against the minimal inhibitory concentration, that number coming up again, the MIC, right? So Rifampin is either 2 to 4 times less potent than Rifapentine or Rifabutin in vitro. And here are the peak concentrations. Rifapentine actually somewhat higher than that, but just makes the math easy and easy to compare. So you'd say, well, Rifapentine's got the best Cmax or peak to MIC ratio, so that should be the best drug, right? Well, this is total drug, so it's including the amount that's bound to the albumin molecules. And the albumin molecules are really, really big, and they don't move inside of a TB organism. So Rifapentine has to come off of that in order to get into the bacilli. And so it can serve as a storage center, but it's not active drug because it can't drag the albumin in there with it. So if we take the bound drug out of the equation and only look at free drug, at least on the peak to MIC ratio, Rifampin is actually better. Right? So the debate continues of which of these two drugs ultimately will be the preferred rifamycin. And you can make an argument for either one. We'll talk a little bit about that today, but it's not the primary focus of parsing out those two drugs. So here is an old study. It was a late breaker once back in 1969 when I was 10 years old, but it's not a late breaker now. And it's been out for a long time, right? So these studies were done in inbred mice. Okay, so the nice thing about inbred mice is that you can get a whole group of them, and they're all 6 weeks old, say, and they're all about the same weight, and they're all from the same family, and they all are more or less the same pharmacokinetically, much more so than humans. So you can give standardized doses, and from mouse to mouse, you're going to get pretty much the same concentrations, right? So here's the dose that we give, 10 mg per kg, but at least in this experiment, which was 10 weeks long, there's still plenty of viable bacilli that could be plated out and measured, and then there's other forms that might be there that are very hard to measure on solid agar, so there actually could have been more bugs than this. But if you went up to 40 mg per kg and the attendant concentrations with that, at least under the conditions of this experiment, there were no viable organisms left. Now, this is not a relapse study, which is really what you want to ultimately do. This is just a cidal study. Nevertheless, it's very encouraging about the dose effect of Rifampin. So this is what we're talking about. As you make this AUC bigger and bigger and bigger relative to a standardized MEC or MIC, you get more killing, just like this row here. And you see the number of bacilli dropping off fairly dramatically. So if it were my lungs at the end of the day, if I had no more toxicity from this dose relative to this dose, I'd certainly rather 0 bacilli residing in my lungs than a whole pile of them residing in my lungs. So right from the get-go, there was a lot of questions about what's the dose of Rifampin. And I've already said that the 600 milligram dose is the minimally effective dose. So the debate started in '72, and it really hasn't stopped. Here's a study done by the British Thoracic Association, now British Thoracic Society, and it's very much modeled after the BMRC studies, which were done outside of England. This was done inside of England. And we get pretty standardized results. This is what we expect. Roughly 70 to 80% of patients will be culture negative at 2 months, and this is exactly what these guys show. But let me call your attention to a couple of things. Just like the BMRC studies, they gave a dose of pyrazinamide that was 35 milligrams per kilogram. For the smallest patients, those under 45 kilograms, those people got 1,500 milligrams. And then the bigger people got 2 grams of pyrazinamide daily, right? We don't usually do that in the United States. And they gave 25 milligrams per kilogram of ethambutol, not 15, right? So they were giving more aggressive doses, and we still say that we're going to get these results, but we don't give those kinds of doses to our patients. But meanwhile, on the other side of the English Channel, Christ and Pertet were looking at high doses, and they were giving 1,200 of rifampin and 900 of isoniazid either daily or every other day, along with daily streptomycin. And they got these kinds of results. And notice they didn't use pyrazinamide, which certainly adds to your 2-month culture negativity rate by about 13%. So if we just stand these studies side by side, this is not a statistical comparison, but it does kind of look like if you give bigger doses of the drugs, you shift your endpoints a month earlier. So you killed off, in most patients, the largest number of TB, which is exactly what you want to do. So even this old study from '76 is very encouraging. They didn't have flu-like syndrome, and even with highly intermittent rifamycin regimens, you usually don't see that until about 3 months into the regimen. So here are 2 references that you can read more about. One I'll come back to, and it's also on your suggested reference list. Speaking about doses of rifampin. So here are my consiglieri, my uncles in the business. And most of you know that this is Danny Mitchison. Officially, he retired last October at age 96. This is Jacques Grosset. He's 86, and he continues to do TB research at Johns Hopkins University. And this is my colleague from National Jewish, Leonid Heifetz, who sadly passed away at age 89 last May, and I do miss him dearly. This is near Colby College in New Hampshire, and I had a chance to talk with these guys about the history of the doses that we give, and had excellent input from them. And subsequently wrote this paper, which was previously mentioned, in 2003 about what is the right dose of rifampin. Now, also at that 2001 meeting, gentlemen from AstraZeneca from their Bangalore, India branch were there, and we had a nice discussion, and they went back and did these studies, and this is a 6-day acute infection model of TB. And as you can see, AUC to MIC is a main driver for these drugs, and in this case for rifampin. This is where we are on the curve with the standard dose, which is barely effective. And that's speaking to Denny's point about the minimal effective dose of rifampin. And you can see that even in 6 days, you can get nearly a 4-log kill if you're willing to really crank the dose of rifampin. And 4-log kill is 99.99% of all the bacilli are dead within 6 days. So that's incredible. So again, the bigger this AUC compared to the MEC or MIC, the more killing that you get. And it's not just true in animals, it's true in people, and we'll get to that. So again, if you're giving a big enough dose, you're going to get a massive amount of kill of TB, and that's exactly what you want. These 2 slides, the last one and this one, are really saying the same thing. They're just showing the picture differently. So let's move from the clinic, or from the lab to the clinic. Enough about mice, and let's talk about people. What happens if we go in the other direction? What if you reduce the exposure of a concentration-dependent TB drug? Well, that was not the intention of this study, but that was the outcome of this study, which is the TBTC study 23, and this is the 23A, which is the PK sub-study. So this has been out for a decade, so this is not brand new. Nevertheless, it's highly illustrative of the point. Right? So this was a study of intermittent rifabutin-based regimens in HIV-positive TB patients. Right? And the results were not subtle. Now, initially, before we had completed the study and then after the study measured all the concentrations, we had the results of the study clinically, but we didn't have the concentrations yet. Everyone focused on the CD4 count, right? And it seemed like the guys with the lowest CD4 count did the worst. But once you controlled for the area under the curve or the Cmax, both were highly correlated, for rifabutin, the CD4 count dropped out. An odds ratio of 1.04 is essentially an odds ratio of 1, which is a coin flip. It doesn't matter what the CD4 count was. The driver was the rifabutin area under the curve. And 50% of the data are in the boxes. So 50% of the data is right here, and 50% of the data or more is right here. And you can see that these 2 are separated. So the guys who not only failed to relapse but had acquired rifamycin resistance had much lower exposure to rifabutin. and they were getting that intermittently, which is a double whammy, because on the days off, you have 0 AUC. So the moral of this story is that if you don't kill the pathogen, you select for drug resistance, and that's exactly what you'd expect from in vitro and animal model studies. And acquired rifamycin resistance was avoidable had these protocols had a built-in dose adjustment scheme based on concentrations. That wasn't part of the protocol. We weren't expecting these results, obviously. So we didn't build that into the study. If we were to do the study over again, we probably would build that in. But further, there's additional cases. So Liz Jenny and Kareem Joseph had 3 cases of this, acquired rifamycin resistance. And then our group here in Florida, in a PK study where you're not supposed to have any clinical endpoints, had a failure with acquired rifamycin resistance. So overall, the AUC is a very big player with Rifabutin. Rifabutin is the poster child for therapeutic drug monitoring because you really don't want to be too high because there is concentration-related toxicity, and you definitely don't want to be too low because you get acquired rifamycin resistance, which is really bad. Right? So there are over 12 reported cases of acquired rifamycin resistance in the literature, and that doesn't speak to other cases that were never reported, but there's a dozen cases in the literature with low Rifabutin exposures in HIV-positive patients. So this is pharmacodynamics in action, but it's not the kind that you want. We're going in the wrong direction here. Interestingly, in conversations that I have as I speak with different clinicians, there's some reluctance among some centers to use Rifabutin therapeutic drug monitoring for these kinds of cases, even though the acquired rifamycin resistance is completely avoidable. It is trivial to change the dose and move the concentrations up. It's very, very easy, right? Why? Well, people think it's too expensive. So let's look at that. Is it too expensive? According to Susan Marks and colleagues at the CDC and around the country, they came up with these estimated costs. So the average garden variety of TB in the United States costs around $17,000. That's the average number. Of course, there's a range around that number. MDR TB around $133,000 and XDR about $430,000 on average. Right? Here are the costs. If you want only measured the rifamycin, it'd be $140 for 2 time points. With Rifabutin, that's 3 and 7 hours. For Rifampin, it's 2 and 6 hours. And there's multiple labs that can do this for you, right? And then if you measured all 4, it'd be around $560, depending on what lab you went to, right? Now, just one case of MDR TB is going to set you back $133,000. So that's a lot of money, right? And you've already sunk the $17,000 for the first treatment, so now you're into it for $150,000, which is approximately 1,000 times the cost of doing TDM. So for $133,000, you could get 950 pairs of concentrations, or you could do all 4 drugs in 237 patients. So again, there's already a dozen reported cases plus whatever cases were never reported. So if we just look at the reported cases, we've already plunked down $1.6 million to rectify the situation for those 12 patients. That equals 11,400 pairs of concentrations. In other words, a pair of concentrations for more than the total number of TB cases annually in the United States. So based on that, I would have to say that TDM, especially with Rifabutin, but in general, is not too expensive when you consider the alternative costs. So as they say on those commercials, what's in your wallet? Now, let's take a look comparing TB to something that is done here at University of Florida and lots of universities around the United States, heart-lung transplants, or solid organ transplants in general, right? So here we have $1.2 million for one patient. And down here, we have $17,000 for one patient, but we're always trying to angle for, can I only treat them 3 times a week? Can I treat them 2 times a week? Can I cut this number? Okay. So what is it about the heart-lung transplant patient that we're willing as a society to pay $1.2 million for that one life? And importantly, what is it about TB patients that we're not willing to pay that kind of money for these patients? And these get into some very difficult societal questions, which I'm not going to rehearse here today. I'll let you think about that. What's the difference between these patients and these patients? And why are these patients worthy of $1.2 million and these aren't worthy of even $17,000? That's a good question. So, do you think these guys here in this turret were thinking, well, yeah, we're about to be killed by this airplane, but at least we didn't use up all our ammunition, you know? I don't think they were thinking that at all. So I think we try a little too hard to skimp on the cost in TB treatment. And for other disease states in the United States, we don't even worry about the cost. So let's get back to pharmacokinetics and pharmacodynamics. Why is acquired rifamycin resistance happening? It's happening because of this. And it's the pharmacokinetics and the pharmacodynamics of these drugs that spell the story for us. So let's look at rifampin. In the blue line, we have the total drug concentration, but some of that's bound to albumin, and it's not really helping us. It's the free drug concentration, which is only about, 15%. It's 85% protein bound, therefore 15% is free drug concentration. So this is the business end here. This is the stuff that can readily go out into the lesions and inside of the mycobacteria. So that's the picture of rifampin. Let's look at rifabutin. And at a standard 300 milligram dose, we barely reach the MIC or don't even reach the MIC, at least in the plasma. It might be a little higher in the lesion, but it's not a lot higher in the lesion. Okay? Now, what if we doubled the dose? Well, we would get above the MIC, but not a lot. And the other troubling thing is we have this low concentration that hangs around for a long time. This is the one with the 36-hour half-life, so it's going to be there for a long time. It's like those Snickers commercials. Not going anywhere? Get a Snickers. Here's rifapentine. Lots of drug, but it's all bound to albumin except for 1%. So I'm going to blow this up so you can see it. Here's the free drug concentration, but the values here are really tiny, right? And it hangs around for a long time, and that's a mixed blessing. So if we put the three together, you can see that rifapentine is in the red, rifabutin is kind of weak and it's in the orange, and rifampin is in the blue in this example, and the MIC is the rifabutin/rifapentine MIC. The other interesting thing is that this AUC, although it's vertical, is pretty similar to the rifapentine AUC, which is horizontal. So overall, they're kind of similar, and that's not too shocking. It's rifampin against cyclopentyl rifampin. Now, if we compare it to the companion drugs, and I'm not putting pyrazinamide on the screen because it's off scale, plus it doesn't really protect the other drugs from resistance. It's doing its own special thing against a special population. So INH rifampin and ethambutol are pretty evenly matched here. They're in the same range, and they're all pretty much gone by 24 hours. Right? There's a tiny, tiny, tiny amount of ethambutol left, but for the most part, they're gone. Now, if we look at rifabutin, it's not well matched. It's way below the other two, and after 24 hours, the rifabutin is still there, all by itself. So if you give an intermittent rifabutin regimen, it's there by itself every other day. Rifapentine is there by itself every other day at a higher concentration, but it's still by itself after 24 hours. Right? So rifampin, INH, PZA, and ethambutol are reasonably well matched pharmacokinetically. So if you were to give them either all daily or all intermittently, they're all going to get in and get out at roughly the same time. You can give the other two drugs daily, and you avoid this problem altogether. But if you give intermittent rifabutin, you will be stuck with sub-MIC rifabutin concentrations as monotherapy about 3 days every week. That's bad. And then with rifapentine, at least it's above the MIC, but it's monotherapy about 3 days a week. So that's why I'm not a big fan of intermittent therapy, especially early in treatment when there's lots and lots of bacilli. I'm not a big fan overall, but especially early in treatment. So coming back to that question that keeps coming up, what is the right dose of rifampin? So Martin Bory had a really nice poster at the CROI meeting in 2013, and happily some of this has been published. So let's get into that. There's two nice papers by Martin and his colleagues from the Netherlands, the first in the gray journal in 2011, and then in the blue journal in 2015. So we have the blue and the gray. It's kind of a Civil War theme, I guess. But nevertheless, these are very good papers, and I encourage you to read them in detail. Right? So what did they have to say? Well, they did a series of 3 studies, which were underway at this time in 2011 and now are approaching completion. So they did a PK study in TB patients, and they did dose escalation. And we'll talk about that in detail. And then they did a phase 2 study, and in our group, which includes Carol Mitnick at Harvard and Jerry Davies in Liverpool, England, are doing another study very much like it, down in Peru. And then the third study that our colleagues from the Netherlands did was a phase 2b study of the highest tolerated dose in 200 patients across 3 countries. I think that is proceeding towards completion as we speak. So what did they find in the first study? That's the one that was published in 2015 in the Blue Journal, and they went up to 35 milligrams per kilogram. Now remember the study by Ludo Verbis, the one from 1969? He went up to 40 mg per kg, so this is getting close. But in a 70-kilogram person, that's 2,400 milligrams, 2.4 grams, which might seem like a lot, but if this had been the originally studied dose of rifampin, we wouldn't blink at it. We don't worry about 2 grams of cephalosporins or 4 grams of piperacillin. We don't even worry about that because we say, oh, well, those are well tolerated. Well, I think you'll find that rifampin at big doses is well tolerated also. So they gave monotherapy just for 7 days, and then they added the companion drugs for days 7 to 14. And the adverse effects really were not dose-dependent, and they got more than proportional increases in the peak concentration in AUC. So as you get bigger and bigger doses of rifampin, you saturate some of the processes that spit it back out into the bile and into the gut, and you get a BOGO. You get a buy one get one free. So you get more than proportional concentrations as you escalate doses of rifampin. The opposite happens with rifapentine. The bigger the dose, the lower amount as a percentage, the lower the bioavailability of rifapentine. But you can escalate rifapentine doses also. Right? So here there was high inter-individual variability. Knowing the dose didn't tell you what the concentrations were. Measuring the concentrations told you what the concentrations were. And the greatest reduction in the sputum colony counts was with the highest concentrations, which is exactly what all the mouse models and the in vitro models told us. It's exactly the story from Rifabutin, except we're going up instead of down here. Right? So this is going in the right direction. And then the last paper I'm going to talk about is the study about what's called 29X, or high-dose daily rifapentine, and the study in the Blue Journal by Susan Dorman and colleagues with the TBTC. So this was a prospective randomized study of 3 doses of daily rifapentine, and unlike rifampin, which is better on an empty stomach, rifapentine is better with food. And they compared 10, 15, and 20 mg per kg to the standard 10 milligrams per kilogram of rifampin. I should have put of rifampin in here. But anyways, they're comparing it to a standard TB regimen with rifampin. Right? And all the patients got these companion drugs. There were 1,135 patients assessed, but only 334 patients actually made it through the study. So 70% of the people assessed were eliminated a priori. Now think back to those BMRC studies where I was saying, about 10% were not included and 10% dropped out for overall, you don't have 95% efficacy overall because you really only have about 75% of the patients to 80% of the patients to evaluate, right? So here we have additional patients who were excluded from the study. And then there's the 3 types of analyses: the per protocol as done by the BMRC, the intent to treat, in other words, if you're randomized, you're in the analysis, and then the modified, which is usually you have to have a certain minimum number of doses to be in the analysis. So you can see the 3 different analyses here. And it looks like on this particular display, some of the numbers shifted. So the lower row, you have to picture it being under the other ones, right? So we have the rifampin and then the 3 rifapentine arms. And if you look at the number of patients who are in the per protocol relative to the intent to treat analysis, it's close to that 75% number that I mentioned from the BMRC study. So not everybody is able to be analyzed when they go into a clinical trial if you want to take everything into consideration per protocol. And all the old studies were done per protocol. So that means a lot of people were excluded. So the doses were well tolerated. That's really good news. 254 were evaluable with the modified intent to treat, and the culture results were done both with solid and liquid media. And here's the punchline. There were no statistically significant differences among the 3 rifapentine arms based on their assignment to the group or the actual administered rifapentine dose in milligrams. In other words, knowing the dose told you very little about who was going to do well and who was not. However, the high rifapentine exposures, that AUC, those were associated with sputum sterilization at 8 weeks. The higher the AUC, the lower number of bacilli, which is exactly what you'd expect from everything I've told you already and from all the old studies. And this has been true since 1969. The percent of negative, culture-negative patients was highest in the highest dosing arm, which isn't really too surprising, but it wasn't a clear trend and it wasn't statistically significant. It was only when you really took into account the PK and the PD that you had these striking differences among the groups. And so PK, PD evaluations provided important insights, according to the authors. Right? So the higher the AUC relative to the amount you needed to inhibit or kill, the better these drugs work. Now, going forward for their phase 3 trial, they state a dose will be selected that ensures most patients achieve the target AUC, especially given that TDM is not feasible in most high-burden settings. So, yes, doing that in the context of a phase 3 trial would be difficult. It would be challenging. However, it's not impossible. But if you look at the situation clinically, well, it certainly implies that if TDM were feasible, they would do it, and it is feasible throughout the U.S. and Canada and throughout Western Europe. So, as we move towards conclusion, it is not possible to give a drug for the explicit purpose of avoiding toxicity. If you're afraid to give the drug, don't give it. If you want a guarantee of no toxicity, don't give it. But if you find that you have to give the drug, then you have to accept some probability of toxicity, and not all drugs have concentration-related toxicity, including Rifampin. Right? So the best way to avoid the toxicity is to give the most effective doses for the shortest possible time. Get there firstest with the mostest, and get out. Rifamycin efficacy is clearly concentration dependent. It depends on the Cmax to MIC and the AUC to MIC, and there's really no way of getting around that. The best way to achieve your endpoint is to measure the exposure and achieve the concentrations that you decide that you want. So you can dial a dose with the Rifamycins and the other TB drugs. You can concentrate them inside of your patient to the point where you know that you're above this MIC, which, as mentioned already, was originally tied to the plasma concentrations in humans. Now, there's always a discussion about TDM, and I'm not going to belabor the point beyond what I've done already. The decision to use it is the same as any other lab test or any other radiological test. There is no prospective randomized trial of how many CBCs with DIP you should get for TB patients. There's no prospective randomized study of how many CAT scans, if any, you should get for TB patients. You get them when you need to know something. I'll go on further and say there are no prospective randomized trials of parachutes. People just implicitly understand that, yeah, if you fall out of an airplane at 10,000 feet, you better have something to slow you down or you're going to go splat, right? So none of these tests guarantees the outcome, but they all help you make a decision. And in the case of TDM, am I given the right dose, yes or no? Right? Do you have to use TDM? Of course not. You don't have to use TDM, but if you keep doing what you've been doing, you're going to keep getting what you've been getting. And what is that? You're going to keep getting this. And this, in statistics terms, is an asymptotic process. We have come in at a plateau, right? And this hasn't changed hardly at all for over a decade. So if we keep giving the standard doses to every TB patient, this pattern is going to continue out ad infinitum. Right? It's just not going to change. If we want to change the pattern and we want this less than 1 year, we're going to have to do something different, either bigger doses or dial a dose based on TDM, or both. So currently we have an 89% effective regimen at 12 months. That's not 95%. It's not 6 months, and it's certainly not 4 months. So if you do the same thing, you're going to get the same. TDM is one tool. It's not the only tool, but it does allow you to individualize your therapy, and it allows you to optimize the PK/PD in your patients. And we've just proven with animal models and human models that this is the driver for efficacy. So as Ron Reagan would say, trust but verify. Or in Russian, it's doverye no proverye. So with that, I'd like to give thanks to the chemists in the lab, T.J. Zagurski, Chung-Mi Kim, Emily Graham, John Kirkham, our client service person, some of some of you may have spoken with Roger, so it's Roger Sedlicek, and my graduate students. Now Dr. Al Sultan has not only a PharmD, but he's got a PhD, so he's Dr. Al Sultan. And then Tobias Hendricks, and then my pre-pharmacy students, John Apple, Yang Zhao, and Tony Tablante. So with that, go Gators. Thank you.
Chuck, that was fantastic. I really, really appreciate it very, very much. And I really have to say I want to thank you for putting together what I think is an exciting topic, especially for all of us doing TB. I have to be honest with you, Chuck. I mean, this whole concept of using higher doses of rifampin is almost sacrilegious. I mean, I think you're speaking blasphemy, because for all of us, we've always been trained that 600 milligrams of rifampin is the only way to go. I mean, and so, I want to, we have a couple questions I want to talk about, but I kind of guess want to bring you back to, a point you made, and I just want to let you bring this point home, which is that the whole concept behind using the fluoroquinolones to shorten the regimen was so that we could get better sterilization, And if I'm hearing you correctly, and I know you didn't say it directly, but if the higher doses of the rifamycins, specifically Rifapentine, especially with study 29, was suggesting higher culture negative rates by 2 months or higher rates of sterilization, I mean, I guess, if I don't want to put words in your mouth, but I guess that would suggest that it is possible that we may be able to shorten regimens utilizing higher doses of rifamycins. Would you say that's correct?
Yeah, and that will be the focus of what will be called Study 31 from the TB Trials Consortium, which is going to be an extension of the data that I just showed you, the Susan Thorman paper from the American Journal of Respiratory and Critical Care Medicine. So that was a phase 2 trial, and now they're going to roll that out as a phase 3 trial to see if high doses, and it'll probably be the 1,200 milligram dose, daily with food, for patients with tuberculosis could be a 4-month regimen. Now, time will tell whether it is, or if a higher dose of Rifapentine or a higher dose of Rifampin would be the preferred weapon, and that's a whole discussion that could be held, and it's almost a separate discussion of which rifamycin is best. At any rate, yes, of the drugs that we know are sterilizing, we've got the rifamycins and we've got pyrazinamide. Now, the fluoroquinolones clearly are bactericidal, but they may be more like INH-type drugs as far as their dynamics in TB patients than being like the rifamycins. Now, the last word on that's probably not been said, and as you know, there is a high-dose levofloxacin study going on right now. So there's more to be learned about this, but at least at the doses that were given in those studies, there was insufficient added sterilizing activity from the fluoroquinolones to shorten the regimen under 6 months. So if you really want to have a shorter regimen, you're going to have to go with something that you know sterilizes. So you can either crank the dose of rifamycins, or you can crank the dose of pyrazinamide, or you crank the dose of both. And right now the focus is on the rifamycins. It doesn't mean that the PZA issue will never be visited, but right now we're focused on the rifamycins.
So, let me ask you a question. I mean, it's kind of wild to me that, with the fluoroquinolones and, the 4-month regimens, it made a lot of news. I mean, they were all over the, not only just news in the medical literature, but it actually made news in the lay public. I'm kind of interested that these, the results of Study 29, the investigations really haven't, gotten more play.
Well, I guess we're just going to have to, try to set aside the whole Donald Trump show and try to upstage him with high-dose rifamycins. What gets into the media is always a mystery to me, so I agree that, this one kind of flew under the radar, and at least, for the general public, not to the people who study pulmonology and infectious diseases, but the general public didn't hear about Study 29X.
I got to say to you, I'm not so sure even the TV public, the TV community really, got a lot of play. I still think it's out there, and that's why we wanted to put this out there to get people to start to think about it. And we see, Dave Miller actually asked a question about this, and I guess I want to know how, I agree with him. I mean, I think it's a little too early, but do you see any implications of this line of thinking? And do you see that maybe, maybe some suggestions in new guidelines or anything like that? Dave is asking.
Well, the guidelines will come out, and the guidelines involve a lot of organizations, including the ATS and the IDSA and the CDC. And they're not going to stray too far from what's already either been approved by the FDA or has been studied adequately in a phase 3 trial, right? Unless there's simply no other data and it's a critical question, right? So I don't anticipate that the upcoming guidelines are going to explicitly recommend routinely giving high-dose rifamycins. But hopefully, the guidelines are going to be an online vehicle in the future and can be updated much more like the HIV guidelines or the opportunistic infection guidelines, that they come out much more frequently. As we look at the current TB guidelines, there was the 1986, the 1993, and the 2003 guidelines, and essentially, there's papers that might be published, but there's no new treatment guidelines since 2003. That'll be rectified later this year, but the last published one is 2003. And just a quick aside on guidelines, as you know, including some of the people here on the call today, several of my friends are pulmonologists or ID specialists, and those are the people who, on All-Star Cast, produced the TB guidelines for those 3 years that I mentioned, 86, 93, 2003. Interestingly, as far as card-carrying members of the committees, there were no pharmacologists on those committees, even though TB treatment is essentially 100% drug therapy. Now, if I were to write surgical guidelines, maybe with some of my pharmacy colleagues, and we might write in really good English, and I would use the word ligate a whole lot, but a surgeon reading that might say, well, these guys aren't surgeons. They never cut anybody. So as pharmacologists look at the TB guidelines, they quickly pick up on things that might not be there if there were more pharmacologists on the guideline panels. That's my little editorial for the day.
Yeah, I agree. The only thing I would say about that, and I totally agree, and then I want to go into, there's a lot of questions, but I also want to make a comment, and I wonder how you feel about it, that there is kind of a little bit of a, sometimes opinions that may differ somewhat between pharmacologists and clinicians, which I think are healthy. I mean, I think sometimes what we get into is sometimes you'll see recommendations that are made by one consultant, and then the clinician will come along and make another. And I think people want it as black or white. I think you'd agree that without more data and more information, a lot of times this stuff is gray.
Well, I've been on enough different guideline committees, and I actually was able to contribute a small amount to the 2003 guidelines. Very specific questions were asked, and I answered those, but I wasn't a card-carrying member of the 2003 guidelines committee. But I've been on other committees for drug-induced liver disease or opportunistic infection in HIV, and I'm on the current panel for the TB treatment guidelines. And I think especially in the past, sometimes the strongest opinion leader carried the day. And this is what I did in my clinic, and I'm very famous. So sometimes that influences the wording in the guidelines. And I think a quote, I don't know if it's original to Phil Hopewell, but I just love it. Phil said, "There's a fine line between dogma and dog manure."
Yeah, I agree. So let's have some, we have a lot of questions coming up, Chuck, and it's great. So, I guess John Walkington is kind of alluding to something I think that's important to bring out, which is the whole idea of one size fits all. And there's a couple other questions where people are asking, do you think they'll be recommending 15 milligrams per kilogram? Do you think they'll be recommending 20 milligrams per kilogram? But I think from what you're saying, and I just want to clarify this point, that one of the things that is key is that increasing the dose does not necessarily mean that you're going to increase the AUC in a totally logarithmic manner, and it's not highly correlated. So I guess the question is are you recommending, are you suggesting a two-pronged approach, both by increasing the dose, because obviously increasing should increase the area under the curve, but ultimately what study 29 and other studies are showing is that it's the area under the curve, not the dosage, that's really making the biggest difference. Is that, you think, a fair statement, or do you think I'm off base on that?
Well, David, I always think you're off base on everything, but the statement itself is fair. So, yes, and you'll see this as the high-dose Rifampin studies are published, and you clearly saw it in the high-dose Rifapentine study. There is wide interpatient variability, and that's just built in to the way your body handles Rifampin, Rifapentine, and Rifabutin. And there's no way to get around it. It's the way your body deals with that type of chemical, right? So you can have 10-fold, 20-fold, even 40-fold variability across the population. So if you give one dose to the person, one person might have 1 microgram per mil as the peak concentration, and somebody will have 40 micrograms per mil as the peak concentration. And the AUCs would move with that. So as you give a bigger standard dose, the low end of the range starts to rise. So what we'll find, I think, from the high-dose Rifampin studies is that the 1,200 milligram dose is somewhat better than the 600, and the 600 might have people that had 1 and 2 micrograms per mil, and the high dose would have maybe 3 and 4 microgram per mil as the low end of the range. So you know, rising tides raise all boats. So rising doses raises the minimum concentration, but it doesn't achieve routinely the desired concentration. So there's two different things. So I think ultimately much higher doses of rifamycins will be used, and they might be in the 2 to 4 gram range. It's an unfinished story, so we just have to wait and see what happens. But nevertheless, you're still going to have that high variability from patient to patient. And yes, you can just give them the standard dose and hope for the best. But in military terms, they will tell you hope is not a strategy. You don't say, well, I'm just going to put 1,000 guys into Syria and hope that things work out. You know, that's not a strategy, right? So if you want to know that you're hitting the target, you got to measure it. You got to measure something. Sputum doesn't really tell you what you really want to know, because even at 2 months, it doesn't necessarily tell you what you want to know. You're happy if it's culture negative at 2 months, but they could still fail, and 20% of the patients are still going to be culture positive at 2 months, and they can still be cured, right? So it's a very inexact tool. Serum concentrations get you closer to what you want to know, because it's telling you, am I hitting the target? Am I at least getting enough into the blood? You ultimately would like to know that you could give some kind of labeled drug and see it in the lesions of your patient, but we're nowhere near that.
And we'll get to that in a second, because I mean that I think is one of the issues here. But hey, Chuck, let's be honest. You know, let's talk about the levels for a second, because it's not just the expense. I mean, the other thing is that they're quite difficult to do. I mean, if I'm correct, Chuck, you got to draw the blood, you got to spin it down, and then you got to put it on dry ice to get to you. So do you think it's only a price issue, or is it also an issue of what you need to in order to do the levels? And is there maybe also another way or something in the horizon that may simplify that?
Well, you know, whatever you consider difficult is going to be from your frame of reference. So, you know, I already mentioned heart-lung transplant patients, and those people have, you know, their sirolimus, tacrolimus, or the cyclosporin measured all the time. They are on voriconazole, posaconazole. Those are measured all the time. They're having all other kinds of labs done constantly, and that's just considered par for the course, and nobody really worries about that. Or if you have a diabetic patient, you're going to have them on a finger sticks and glucosometer all the time.
A finger stick and a glucometer, Chuck, you know, is not spinning it down and freezing it, you know. And, you know, let's be honest, a lot of the ones where that happens, those patients are usually in a more intensified, setting, such as a hospital.
Yeah. Well, you know, it all comes down to what you get accustomed to doing. So, you know, if you have a patient in the hospital or on aminoglycosides, you're not going to hesitate to check the concentrations, and that's true for vancomycin in most centers, and people don't really worry about it. If you're in a TB clinic, you may not have the lab right there. It's more of a hassle. So there's no doubt there's a certain hassle factor, but it's identical to drawing a chem panel. So people are very accustomed to checking LFEs and other blood tests, including the CBC with differential, in TB patients. So the procedure itself of, you know, putting a tourniquet on and getting a blood sample is identical. What happens downstream is really not the clinician's problem, it's the lab's problem most of the time. and that the lab has to ship it to one of the laboratories that can actually measure the concentrations. Urine concentrations don't really tell you what you want to know, so I don't see them as a ready replacement. But at least, across Europe and the U.S., there are multiple labs that are able to do this. I don't know all the current prices, but I'm sure they're all more or less in a similar range of concentration or prices for the concentrations. So yeah, there's a hassle factor, but if you're treating without any measure of are you delivering the drug, yes or no, then you're basically hoping that your patient is the average patient.
And I agree. I mean, I'm just saying, just to put that out there. Let me ask you another question, Chuck. Yeah, but the other question comes down to, Chuck, is that, so what about, and I know it's tough and we don't know, so I'm going to put it out there. So, Chuck, we do a lot of drug levels. We've been doing it for a long time. That's how, unfortunately, we got to know each other. So here's always been my question. I don't have an answer, and, I'm wondering what you think. So let's say I have a patient who now for the last 6 weeks has had a low level because, I put him on meds for 2 weeks. I drew a level. It was low, increased the dose. It was still low, increased the dose. And finally I get it 6 to 8 weeks, or let's say even 10 weeks out. Do I prolong their therapy, Chuck? I mean, even if they became culture negative at 2 months, I mean, do you, what are you recommending? Do you prolong? Do you try to get at least 4 months of therapy after the levels are adequate? I mean, I know the answer is, I think you're going to say that the answer we haven't found out, but I'm interested in what your approach is. What would you recommend?
Well, you're correct. You don't know. So, if you look at centers where they almost never do therapeutic drug monitoring, question is moot. They don't do the monitoring, so they would have just treated the patient that they would have, however, they would have treated them anyway. And then there are suggestions that, patients who are very much below normal body weight, you might want to treat those longer. Those with extensive cavitary lesions, you might want to treat those longer, like the 9 months. And those who are still culture positive at 2 months, you want to treat those longer. So those are pretty general guidelines for treating longer, but the whole focus has been in trying to treat shorter, not longer. So that's not really moving the ball forward. It's just basically losing ground if you go that route. If you have low concentrations, personally, the way I would look at it, the lower they are, the less killing that you did and the more bugs you still have in that patient. Now, sputum samples, it's really a test of the willing. The patient has to be willing to produce and able to produce a sputum sample. And if either of those is not true, then you really have no measure of how your treatment is going other than, weight gain and defervescence, and those are really nonspecific. So I would say, it's a judgment call. It will always be a judgment call. One could argue that if you measure the concentrations earlier in treatment and then you push the doses in response to low concentrations, you get them closer to what was the average BMRC patient faster. And if the doses ultimately become bigger, you'll get them closer to those higher doses, whether they're Rifapentine, Rifampin, or whatever. And so I would say, get to the concentrations that you want as quickly as possible.
Yeah, and I just, as a comment, then I want to go forward, but I agree with you, and I, in our experience, looking at, hundreds of samples, we're probably over 500 in 500 different patients that were treated. The vast majority of patients who use Rifampin 600 milligrams a day will have lower than expected levels, and you're right. I mean, so by the time we finally get the levels up, is usually at a time, to be honest with you, that the patient's already starting to become culture negative. And when we really need the levels, which is early when there's the most bugs, is probably when we have the most organisms. Now, granted, I have to say the vast majority of these patients do well. But there are, as we all know, about 20% of patients who do not become culture negative within 2 months. And you're right. It seems that if we would start the doses higher earlier, especially right from the beginning, when we need the drugs the most, when sterilization becomes the most important issue, I think we'd be better off. And I know a couple of people have asked, are we, and I hate to say it, but are you recommending increasing the starting dose higher than 600? I don't think you're in the position to say Chuck says, but I think that more studies need to be looked at, if I'm correct.
Well, yeah, I don't think there's going to be a guideline that says in 2016 this is the CDC, IDSA, ATS recommendation. No, I don't expect that to be the case. But just like any drug, I mean, there's sort of off-label uses. You use drugs for non-tuberculous mycobacteria. There are no drugs approved for non-tuberculous mycobacteria other than leprosy, and I'm really here referring to, well, I shouldn't say no drugs approved because M. avium and disseminated disease is a special case. But you get the point that we use drugs in indications for which, the FDA hasn't rendered a judgment yet because there are insufficient data. So in the case here of, if you have a patient that you want to start a higher dose of rifamycin based on what is published, and there are published studies now for Rifapentine and for Rifampin, and there'll be more coming, then you can, as a clinician, say, I think this is in the best interest of my patient, and make that call. You can do that with any drug. You just have to have a rationale for it, and best to document that in the chart. This is why I'm doing X, Y, or Z. But I don't think you're going to see the FDA or the CDC making a blanket recommendation for escalating the doses at this time. I think in the future they will, but I don't think they'll do it right now.
Right. I think that's really well said. And, there's a couple of people, as a matter of fact, my favorite question of the day comes from a veterinarian, and so I want to thank him. And he says, that in animals, in his field, they never talk about a straight dose. It's always based on weight. But again, Chuck, I know I'm beating, and I know I shouldn't say this after I said vet, but I'm beating a dead horse here. But bottom line comes down to is that it's not just about dosage based on weight, but making sure those levels are adequate. I mean, that's what the studies are showing. It's really more, making sure that you have a good area under the curves. And I want to make, a point because the questions are coming back, that we keep talking about, milligrams per kilogram, but in reality, it really is making sure we, like you said, those traces, we know where we are. We know if we're hitting the target, and I think that's taking it to the next step. Hey, Chuck, let me ask you a question here. There's a bunch of questions about intermittent therapy, and, you made some statements about, intermittent therapy and why you stay away, but yet, Chuck, in fairness, and let's be fair, and this is where clinicians and pharmacologists, we kind of butt heads a little, studies clearly show that intermittent therapy works for the vast majority of people. Am I correct?
Well, there are lots of data out there, and you should look at all of the data. So, the so-called Denver regimen, I think that was 135 patients that were studied. So it wasn't exactly a giant study, but clearly it worked, okay? And the other point is that you have a spectrum of disease. So if you have a patient who comes in with minimal disease, you probably could treat them with even less than 6 months of therapy or with intermittent therapy, and chances are they're going to do fine. We even know that from pre-antibiotic days, roughly 20 to 25% of the patients would spontaneously cure. And, about 50% would die, and then about 25% would be what were called good chronics. So they would be sick, and those are the most dangerous ones because they kept spreading it, So we know that some patients, you just have to give them a nudge in the right direction, and they're going to be cured, right? If you look at some review articles by Wingwei Yu and Jacques Grosset, looking at all the different regimens, intermittent and daily, and I think Dick Menzies has done this as well, every decrement in the frequency of dose, you lose a certain amount of efficacy. So if you go from 7 days a week to 5 days a week, you lose some efficacy. 3 days a week, you lose more. 2 days a week, you lose still more. And it's really important early in the treatment to give daily doses. So we'll see what the new guidelines have to say about the Denver regimen versus staying for 2 months with daily doses. But, if you don't give the drug, your AUC is 0. Okay. Now, you can still give the drug and still have an AUC close to 0 because the patients can malabsorb it. So the way I look at it, you've heard of this in the lead up to the Gulf War, and I don't want to overdo these war analogies, but you heard about shock and awe. And we weren't going to just put in like one brigade of guys. We were going to put in thousands, hundreds of thousands of guys to deal with that problem. And if you look at the Normandy invasion, in one day, 150,000 guys went ashore in France, okay? So they weren't trying to just, play for the tie. They were going for the win, right? And in TB, every dose that you give, you kill more bacilli. So you have an incentive to give more doses. And if we're going to go to a 4-month regimen, it ain't going to be an intermittent regimen. It's going to be a daily regimen.
So Chuck, let me just stop 1 second just to say it's 2:30. I know that's what we were scheduled for. I want to thank everybody for joining. For those who can stay on, we're going to just do a couple more questions because Chuck, you broke the bank here. But I wanted to just thank everybody who has to leave for joining today. And if you have a question that you want answered, if you email the SNTC, we'll get it answered. But in the meantime, for those who can stay on, we have a couple more questions that I think and points we'd like to make. So we thank you for staying on. The other thing I'd like to make another statement about is that for those of you in the Southeast region, as you know, the Virginia TB Foundation has been so gracious and so supportive in putting together a grant for the Southeast region for patients who you feel may need drug levels and you don't have a way to pay for it, that we may be able to support that thanks to the Virginia TB Foundation. I just want to make that point. So I want to just, again, thank you. But Chuck, you're not going anywhere. I just have a couple more questions and points. So Chuck, you made a really very dramatic statement there that you promised that it won't be intermittent. I get it, but let's be fair here, Chuck. You've talked a lot about the pharmacokinetics in the patient. What you haven't really talked about is the organism and the phase of disease and the actual growth rates of the organism. So Chuck, as we know, early on, you actually have organisms in different phases of growth, and that's where it really becomes important to hit hard. But as you know, Chuck, once we go into the phase where the quote-unquote, the patient becomes culture negative because the number of organisms have decreased and also the places where the organisms are seeking refuges change, the bottom line is that the amount of times you have to hit them may change. Do you want to comment on that at all?
Yeah, well, there's the model that was proposed by Denny Mitchison and a related model by Jacques Rosset. And so there's log phase growth organisms, and those are the ones that are easiest to grow, and they're the easiest to kill because they're in full function. They're making cell wall, they're making proteins, they're doing the whole show, and we have drugs with different mechanisms of action. So if we give 4 drugs, we can really attack at multiple places, kind of like we do with HIV treatment, giving different types of drugs to attack at different stages in the virus's progression. So the log phase growth organisms are the ones that are multiplying and spreading and making more lesions because your immune system responds to it, and that results in some cases in cavitary lesions. So there's those guys, and those are the ones we can readily measure. Then there's the ones that are purported to be in the rind in the cavitary lesions, that all this dead material and it's very acidic, and that's where PZA is thought to work the best. And then there's the non-replicating persisters, which may be extracellular, they may be intracellular, and those non-replicating persisters, Rifampin does the best job, or the Rifamycins do the best job at killing those. The problem is, in a given patient, you have no way of measuring that. You have no way of saying, oh, this guy's got 40% non-replicating persisters, and that guy's only got 20. It's completely opaque to us, right? So it's a very useful tool, and then we can mimic that in the animal models that we do, or in the hollow fiber models that we do, or other in vitro models. We can mimic those different stages of growth or stasis, and we can see what drugs do something or not do something. But as a clinical tool, it's really not particularly useful. It is true that you kill with isoniazid about 0.6 logs of organisms per day for the first couple of days, and then it plateaus out pretty quickly. So you can pretty dramatically make somebody smear negative within days, if not a couple of weeks, of treatment. But that doesn't mean that bad things aren't happening and that those organisms cannot rebound and reestablish log phase growth if you back off. So there's absolutely no doubt that there are intermittent regimens that have shown efficacy. I'll just say, wait for the new guidelines to come out and look up the papers by Wing-Wei Yu, Jacques Rosset, and Dick Menzies on the topic of intermittent therapy, and then decide for yourself.
So Chuck, one of the things you talked about, and we just said is the different phases of growth, and there's a bunch of, you can't talk about the Rifamycins without HIV coming up, and obviously in patients who are HIV positive who are very, very immunosuppressed, the whole model's changed somewhat because the immune system really is not as effective in containing. But some of the questions we have here is like, so what do you think it is about HIV positives and acquired rifampin resistance? I mean, what do you think happened there? We're getting a couple questions, about HIV and how the rifamycins may be affected by HIV.
Well, there's nothing like an intact immune system to win the war. So, it is analogous, I suppose, to the situation of meningitis, where it's a sanctuary state. You don't have a lot of white cells in the cerebrospinal fluid, typically, and once the bugs start multiplying in that cerebrospinal fluid, they're kind of protected. Not all the drugs get in there. So, that's a place that is relatively immunocompromised compared to, a thigh muscle or a lung, right, where you can easily get blood in there, easily get white cells in there, easily get drug in there. So, I mean, it's a bit of a stretch of the analogy, but nevertheless, clearly, you have patients who are immunocompromised, and there's no residual effective immune system to mop up what the drugs don't kill. In particular, if you have early in the course of treatment, so the first 2 months in particular of HIV co-infected TB, and you go to an intermittent regimen at that point, every other day, I mean, immunologically, there's nobody home, and there's no drugs there either. And in those cases where Rifabutin was studied, you have residual low concentrations. Now, in vitro, if you go to a lab and you want to select Rifamycin-resistant organisms, you would plate them with 1/2 times the MIC, 1 times the MIC, and 2 times the MIC, and you would try to see what grows through that exposure to the drug. Unfortunately, with HIV-positive patients and intermittent Rifabutin, that's exactly what we did, and we selected for the resistance ones. I mean, this is completely predictable.
Exactly, Chuck. And let me ask you just a comment, because I saw in the I know from study 20 when they looked at, I guess it's study 23, when they looked at acquired rifampin resistance, in the HIV TB TBTC trial, the CD4 count really wasn't an issue. We did some work, and we did an abstract, and I guess we should have published it. But the bottom line is, when we looked at our Florida experience with acquired rifampin resistance, it was like, I think, 12 different cases. And even though CD4 count, you're right, really didn't necessarily come out, what did come out was extrapulmonary TB. And we know that patients with HIV have a much higher rate of extrapulmonary TB. And it seemed like almost every one of the cases of acquired rifampin resistance, at least we saw, and still do see from time to time, rarely, was more associated with extrapulmonary TB than it was actually than even intermittency. But I want to know, what do you think about extrapulmonary TB and low serum levels of rifampin? I mean, do you think that may be a contributor, and how does penetration into other tissues affect all this?
Well, it's not as well studied. Clearly, the guidelines would recommend for most forms of TB with bone and CNS disease accepted, most patients can effectively be treated with a 6-month regimen. Okay? So for bone, many patients treat out to 9 months. For certain forms of extrapulmonary disease where there's a lot of tissue destruction and you don't know if the drug is going to be able to get in there or not, or if you suspect there's some kind of biofilm, which is, TB can make biofilms, like lots and lots of organisms make biofilms. So if basically there's some sanctuary within which the organisms can hide, or you have a person who, maybe is in their 70s or 80s, had TB a long time ago, and they come back and they have this big calcified rind on their pleura, and then now you have TB in there. Yeah, I mean, that's a sanctuary where the drugs may not get in, and you might have some real problems. But it's clearly not well studied compared to, sort of garden variety, if you will, pulmonary disease. So yeah, whenever you think the drug's not being delivered, you're going to have to think about doing something like pushing the doses or extending the treatment.
I think you'd agree, Chuck, extrapulmonary disease in an HIV-positive individual where, because usually extrapulmonary TB is usually very paucibacillary. There's very few organisms. Where in HIV positives, now not only do you have an extrapulmonary where there's poor penetration, but I think you'd agree these patients tend to have a lot of more organisms than would be expected. So now you even need higher, just like you said, levels. And I think that's where the whole, again, I want to point out, the whole, making sure you have adequate serum levels in these cases becomes huge.
Yeah, I can't really argue the point because most of the time,
you can't argue the point. That's
we don't do quantitative cultures in extrapulmonary lesions, so we don't know routinely what that number is. Right. We just know,
one way to do that, Chuck, is you hardly ever see a CSF that's smear positive and an HIV negative, or a pleural fluid that's smear positive and HIV negative. You see it in HIV positive. So even though you don't have quantitative cultures, you do tend to see more smears that are positive in HIV positive patients who are immunosuppressed.
Yeah, and they're also more likely to have positive blood cultures.
Yeah, you're right. You're right.
The other thing that comes up with this is that we now know that that you grow different numbers of organisms in liquid than in solid. So there are certain forms that people expel in their sputum anyway that you can grow in a liquid media, then you can't grow those in solid media. And it is possible that that's a response to the stressors that they're under. And in HIV-positive patients with their immune system not working so well are going to have different stresses, so they might have different types of populations, whether they're, the non-replicating persisters might be in a higher number, for example. We don't really know the answer to that, but yes, they do seem to be a different type of patient.
I agree. So we have one more question. This is from Greg from Kentucky, our pal there.
Hey, Greg.
We all were part of this case, and this, when you talk about pharmacokinetics, I know it's a little off here with high dose, but it really does become an issue that he had a patient that was co-infected, and the HIV physician there wanted to use Cobicstat, and maybe you could talk a little about Cobicstat. And the problem then was that if they were going to use Cobicstat, we recommended that drug levels be done because we were really concerned that the Rifabutin levels, and especially the deacetyl metabolites, would go high. We have actually had 2 cases in Florida where the combination was used and the patient became toxic and unfortunately developed hepatotoxicity from it. So he was asking, if you have to use these drugs, A, would you do drug levels, and if so, would you maybe use 3 times a week since on all the drugs, since the you expect the levels to be high, or maybe only 3 times a week on Rifabutin, or scream help? Chuck, help us here. What would you do?
Well, a lot of times you end up in situations where you'd rather not be there, so, but you get the patients who you get, and they show up, and you have to do something for them. So I definitely do not recommend, at the outset of treatment, intermittent Rifabutin. There's just too much data, and David, you alluded that you had maybe a dozen cases that you didn't publish. Shame on you.
I've acquired Rifampin resistant over 15 years, yeah.
Right, yeah, but that would be doubling the number that I already quoted that are published, right?
Right.
So there's, let's just accept the number you presented.
Oh, I agree with you.
There's 2 dozen.
Sure.
Right? So you don't want to give intermittent Rifabutin. There's not tons of data in TB patients regarding the interaction between Cobicistat and Rifabutin. So what you can do, you don't really need to measure the Cobicistat, but you could measure the companion drug, whether it's Darunavir or one of the INSTIs, but nevertheless, you can measure the effector drug.
Chuck, real quick, just explain what Cobicstat is for individuals.
So once upon a time, people gave boosted protease inhibitors. So they used the protease inhibitor Ritonavir, which by itself is hard to take at full doses, but at doses around 100 milligrams, increases the concentrations of drugs like Lopinavir by blocking the clearance through the liver of Lopinavir. But it also so happens to block the clearance of Rifabutin. So you get a 2-way interaction where Rifabutin is lowering the Lopinavir and Ritonavir is increasing the Lopinavir, and it's also increasing the Rifabutin. So over time, Cobicistat was developed so that it has no antiviral activity, but it does block the cytochrome P453A4 enzyme, kind of like Ritonavir did. Ritonavir has mixed effects on the other enzymes, so it's a more complicated thing to use. Cobicistat is more selective, okay? So it's a enzyme blocker, right? And because rifabutin is partly cleared by 3A4 in its metabolite, which is usually in low concentration, is completely cleared by 3A4, then if you put cobicistat in there, it's like taking the biggest football player from the University of Florida football team, putting him in the doorway of my office and saying, okay, Chuck, go out at the door. And it's like, well, it's not going to happen. There's a giant guy standing there, right? So that's what cobicistat does. So we have to be careful with it, but we also have to treat the patient. So you're going to give them enough rifabutin to be effective and not select for resistance, and then you can check your rifabutin and HIV drug concentrations to make sure that you're not really messing up one disease state or the other.
Okay, so just, we only have a couple more minutes left, so just to stay on different populations. So just a couple questions on, what about rifamycins in pregnancy, Chuck? Like, what would you recommend there? I mean, do you have any comments on, the possibility that pregnancy may affect how the drugs are either absorbed or metabolized?
Well, based on personal experience, pregnant women prefer Haagen-Dazs ice cream. But if you don't have that,
isn't that the husbands of pregnant women, or I'm not so sure. What do you think?
But clearly the rifamycins appear to be safe for pregnancy. So in the United States, we give INH, Rifampin, and ethambutol to pregnant women. In many other countries, they also add the pyrazinamide, and we may eventually come around to do that, at least in the guidelines, for pregnant women. So you generally can treat patients with TB who are pregnant the way you would treat non-pregnant patients. As far as whether there's a profound effect on the kinetics, there does not appear to be a giant effect on it, and I think Helen McElleran has published on this topic. She's an excellent investigator out of South Africa, so you could do a PubMed on Helen McElleran, McIlleron, and you could find more data about TB drugs and pregnancy.
All right, great, Chuck. And what about we had a interesting question. One of our participants is sharing a case, a really tough case, who had miliary TB and had chronic. It looks like acute on top of chronic renal failure, and then the nephrologist advised stopping the Rifampin PZA. So it's kind of interesting because I think you agree Rifampin and PZA for the most part is really not metabolized by the kidney, or at least excreted by the kidney. But I wonder in that case if and again there's not enough here, but I guess if there was a question if the Rifampin was causing an interstitial nephritis, maybe you would stop. But normally, I think we would usually try to continue with Rifampin PZA in those cases. Does renal failure affect the levels in these cases?
Yeah, so in the 2003 guidelines, I did have a chance to contribute in that section about renal failure. So normally we don't change the dose of isoniazid and we don't change the dose of rifampin. We have to change the dose of ethambutol. And then there were open questions about pyrazinamide. I mean, it is metabolized to pyrazinoic acid and hydroxypyrazinoic acid, but those go out through the kidneys. And we don't know for pyrazinamide whether it's the parent drug or one of the metabolites or all three that are toxic to the liver. So we erred on the side of caution, and like the ethambutol, recommended intermittent dosing of both the ethambutol and the pyrazinamide, but at the standard daily size dose, along with daily INH and Rifapentine in patients, for example, on hemodialysis. Now, not knowing the whole case, I'm not sure exactly, if the concern was, as you mentioned, whether rifampin was causing the kidney problem. So that's a pretty rare, but it is a well-published side effect of rifampin. Typically, it's in the context of a patient who has the flu-like syndrome and thrombocytopenia and renal failure. And in those patients, you stop the rifampin and you never give it again. Okay, but that's relatively rare. Not that it doesn't ever happen, but it's not that common.
Right. And just, John again from Tennessee, John Warkton is asking, now that you talked a little about PZA, you made a comment about PZA not providing protection against the development of resistance. And first, is that correct, Chuck?
Well, it's based on the model from Mitchison and from Grosset. As we understand it, And then from some clinical data that they analyzed, it would appear that, pyrazinamide essentially, dresses in black and it's a ninja, and it goes in and it only attacks the organisms that are under tremendous stress in an acidic environment. And that acidic environment, both in vitro as well as in people, seems to be required for pyrazinamide to be effective. Right? So because it's at a place, a space that the other drugs may not be doing anything, and it's really not designed to protect, and the data from the BMRC studies don't suggest that it protects isoniazid or the other drugs from the selection of resistance. So pyrazinamide is a drug that helps us get from the 9-month regimen down to the 6-month regimen. It also seems to add to all the new drugs that are coming out. So it's an important drug, but one of the features is not protecting the other drugs from the selection of resistance.
Right, but still plays a role, because that was the second part of the question. You nailed it. So if you have somebody who's MDR, who is not on INH or Rifampin, PZA, I think, still plays, I think you'd agree, a role in regimens where, where, what do you call it, the INH and Rifampin are not being used, but not maybe in the same way as when they are. Is that correct?
Yeah, there's a great paper by Carol Midnick and her colleagues looking at, whether pyrazinamide, especially if there's questionable in vitro susceptibility, what does it contribute and where? Rather than trying to paraphrase in 10 seconds that paper, if you do a PubMed on Carol Mitnick, MIT, NICK, and pyrazinamide, you will surely find that paper.
Chuck, there's a lot of people here who are writing that they're tired of your homework assignments to have to Google and know. We really appreciate that. That's fantastic, Chuck. Thanks. Hey, let me, while we go, just 2 more questions, then we're going to give you a break. So while we're talking about special populations, you cannot talk about special populations without talking about kids. So what do you think about increasing the dose on kids? Already I think in kids the recommendation is beyond the 10 milligrams per kilogram and goes up to 20. Any data on that, or is that something that still needs to be investigated further?
Well, Peter Donald in South Africa has done a nice job evaluating that, and so I think that the data are in on that. So little children clear the drugs much faster than adults. So their area under the curve is lower at any given dose than they would be in adults. So they need higher milligram per kilogram doses in order to get the same exposure as seen in adults. So the WHO has already upped their recommendations, and you could argue that they could go higher still. Working in favor of the children is they tend to have non-cavitary lesions, so they tend to have, compared to adults, a relatively postbacillary disease. So the children tend to do well. They tend to tolerate the drugs pretty well. And I think Jeff Stark is going to be giving presentations at the NAR meeting on this topic, and I think he also, along with Peter Donald, has a new book that just came out.
And let me just make it clear. I mean, it's not just about the dosage. What about the pharmacokinetics? I mean, are you looking at the same range of like 8 to 24 as the expected levels, Chuck?
Well, the concentrations that you're shooting for are, again, relative to that MIC. So, it doesn't really matter what the host is. You're really focused on the target inside of the host, the organism causing the disease. So as far as we know, the concentrations that are appropriate for adults are the same concentrations that you would try to achieve in children, but on a milligram per kilogram basis, you're going to need bigger doses in children to get there. So
Chuck, just last, and this is the last point because I think it's important to you, because I think you made some very strong arguments and we really appreciate it, and they were great. But, obviously, because we're getting a lot, are you not recommending intermittent? Are you not recommending intermittent? I think you're not in a position, the recommendations stand the way they are. There may be changes, and I think that's what your message is that you think it's important that, we go back to look at the studies about intermittent, what would be your comment on intermittent? I know we've talked about it, but I think we need to summarize it since we're getting a lot of comments about that.
Right.
As you know, with the public health, a lot of patients are placed on intermittent therapy, and the vast majority, Chuck, do well. But I think what you're saying is be cautious, if I'm correct.
Yeah, I mean, just specifically, in HIV-positive patients, I do not like intermittent regimens for the reasons already stated, especially if you're using Rifabutin, because you're exposing them to sub-MIC concentrations every other day, and you're asking for trouble, and according to your statement, now there's 24 cases of acquired rifamycin resistance. So don't do that. Now let's put aside HIV-positive for a moment and just focus on HIV-negative cases, all right? So if you have HIV-negative case of TB, clearly there are regimens that could be used intermittently. If you ask me personally, would I take an intermittent regimen? No, I wouldn't. I especially wouldn't do it in the first 2 months of treatment. And I think the paper by Wing-Wei Yu and Jacques Rosé, and I believe there either is one published or coming out from Dick Menzies, gets into that you lose efficacy with each decrement in the frequency of the dose. That said, it can still be effective, and the less disease your patient has, the more likely it is that it would work.
And also at the phase of the disease, if I'm correct. You know, again, taking into account the number, because when you say less disease, what you're really saying is less organisms, if I'm correct.
Yeah, first there is the issue of, you know, is it week 1, week 6, week 10, and then how many organisms are in that patient, and did they have a big cavity or multiple cavities or no cavities? So there are two things that are working together. And so the sicker the patient, the more bugs they have, the more you need to give daily doses. I think on balance, you're best served, at least for the first 2 months, giving daily therapy. That's my opinion. Yeah. Others disagree.
Yeah, we agree. That's usually it, too. We wait normally. We try to wait until at least the person is definitely smear negative, and if they have a lot of disease, we agree. You know, we try to do it once their cultures are negative, if we do it at all. Hey, Chuck, I can't thank you enough. I got to be honest with you. I think talking with all this talk about battles and war, you definitely deserve battle pay. Having to talk to me this long is beyond what any person should have to endure. But thanks to everything you've said, I think our audience, our participants have really enjoyed it. It's been so enlightening. And Chuck, I'd like to say that I could listen to you all day, but I can't. But other than that, Chuck, as always, you are fantastic. I really want to, on behalf of everybody who's been listening, I really want to thank you. And I want to thank all of our participants for joining today. If you have any questions, please email us. We'll get it to Chuck. And other than that, Chuck, thank you, thank you, thank you. You remain the Chuck, and thank you very much. And Karen, I'm going to turn it over to you.
Thank you for another great presentation. Please be aware that you must complete the online evaluation by 5 p.m. Eastern on Thursday, February 4th, if you want to receive nursing or physician credit. You will have 1 week to complete the evaluation. And thank you, Dr. Peloquin and Dr. Ashkin, for a great presentation.
Thanks a lot. Bye-bye now.